Okay, good morning, everybody. Welcome to Department of Medicine Grand Rounds. Today, I'm going to introduce the introducer, Dr. Rosemary Youssef, who is our chief at the Division of Nephrology here at University of Louisville. And Dr. Youssef, without further ado, please give us a preview of what's to come today.
All right. Well, I am very pleased that Dr. B. Concepcion has agreed to give us our grand rounds today. She is presently an associate professor of medicine at the University of Chicago. She did her undergrad and medical school in the Philippines and then did her residency and fellowship at Rush University. You all have heard of Rush before, I'm sure. And then Transplant at Vanderbilt, where she stayed to be on faculty. And then in 2023, she moved to the University of Chicago. She is what is classically known as a triple threat, publishing on research, doing research in kidney transplant and living donor, giving talks throughout the country. She's internationally known. But I guess some of her accolades that are the most, interesting to me or the most promising is that she was at Vanderbilt known to be the patient advocate, and the patients had voted her or made her the physician, the patient's physician. They loved her there. And then so did the fellows and the residents. They all gave her teaching awards multiple years at Vanderbilt. So I know that we're looking forward to something that we definitely need to do more of, which is kidney transplantation in 2025. How can we do more? Thank you very much.
Thank you so much, Dr. Youssef, and thank you, Dr. Williams, for this very kind invitation. I'm really happy to be here joining you virtually. So, yes, the question that I want to answer today is how can we do more in really focusing more on the organ shortage that we are facing in 2025? And these are my disclosures, none of which are relevant to today's talk. There are no conflicts. This is what my outline is going to be. I'm going to talk about kidney transplantation and the imbalance in supply and demand. So framing the topic as to why this question of how to do more is important. And then talking about how to do it, increasing living donation, reducing organ discards, and also talking about xenotransplantation, which has been in the news in the last year or two. So why pursue kidney transplant? This is an important question for us to understand why patients really, should be thinking about kidney transplant. And that's because it offers superior survival benefit of transplant compared to remaining on the waiting list. This is a classic study from 1999 that shows that um, risk with a transplant early on is increased compared to waiting on the list. So the horizontal dashed line here is the survival of patients who are waiting on the list. And the solid line is one of those who have been transplanted. And as you see, even though there is this increased risk in the beginning, long term, there is a sustained benefit with reduced risk of death. And this graph is actually still holds true today for many things, whether it's for those who are higher risk, for example. So this is a later study looking at patients and their cardiovascular risk and what transplant does for them. So as you can see here, for low risk, there is still some risk in the beginning when you receive a standard criteria donor, which is a deceased donor. Although if you do receive a living donor and you're low risk cardiovascularly, you have immediate benefit. And then for intermediate and high risk, these are folks who have one risk factor for cardiovascular disease, high risk have two or more risk factors, including all diabetics. And you see here again that although there is a higher risk in the beginning, there is a sustained benefit as far as survival is concerned. And importantly, living donor transplant is superior to deceased donor transplant. Not only does it offer superior graft and patient survival, patients usually have immediate graft function, meaning the kidney works right away. There's no need to dialyze post-transplant, although this occurs very minimally for the most part. all these kidneys work right away. And of course, it also means that when one gets a living donor, there's one less person waiting for a deceased donor kidney. Over the last 25 years, kidney transplant outcomes have continued to improve. And you see here the Kaplan-Meier curves of cohorts of patients from 1996 to 1999 compared to a cohort of patients up until 2012 to 2015. And you see here across the board, outcomes are improving. So this is good news. But to really, put this in perspective, although these outcomes are getting better, we have to also frame it as far as what does it really look like as far as 5-year survival compared to patients who, for example, have cancer, which, I think the general public is more aware of, what is the survival when someone has cancer. And you can see here that it's still not great, right? So transplant recipients have worse survival than patients with, for example, breast cancer. Patients on dialysis have worse survival than patients with leukemia. And patients on hemodialysis have worse survival than patients with digestive system cancer. So I think this is very sobering to understand what really is the survival of the patients that we take care of. Now, looking at how to get patients a transplant, the problem is that there is a market imbalance in supply and demand. So in the United States, there's about 90,000 patients waiting for a kidney transplant, meaning they're on the list, so to speak. But in 2024, only 28,000 kidney transplants were performed, and about a quarter of those here in green were living donor transplants. And if you really think about it, who is eligible for a transplant? Well, I don't know that we really know that number because the 90,000 on the list here in orange is a pretty well selected population. But in the bigger scheme of things, there are 550,000 patients on chronic dialysis. And as I've shown here, very few actually get to a transplant. In the United States, it takes about 4 years median waiting for a kidney. And there are definitely a good number of people who are waiting over 5 years. In 2022, that was 12.4%. About 12 patients a day die on the waiting list, and about 12 patients a day are actually removed from the waiting list. So not everyone who is listed will actually get to a transplant. So getting listed doesn't mean that you're on you're guaranteed to get there. In fact, a lot of people end up being removed or actually dying, unfortunately. So we need to do more donor kidneys to do more. We need more donor kidneys to do more transplants. And we know that in 2019, the Advancing American Kidney Health Initiative really set the goal of by 2030, we should double the number of kidneys available for transplant. We're now in 2025. I don't think we're going to get there, unfortunately. And UNOS even had this very robust target of 60,000 transplants. So we're at this point 24,000. So how do we get there? How do you get to a kidney transplant? So I want to just explain some of the logistics and the nuances of how this all occurs. So I'm going to talk about living kidney donation. But before I do that, how does one get to a transplant with a living donor? So you have a patient with advanced kidney disease. Most of the time, they're already on chronic dialysis when we see them. They have to go to a transplant center. There are about 251 in the United States. And then you have a living donor. If they have a living donor who comes forward, so the center can't reach out to anybody, they have to come forward themselves. They also usually come to the same transplant center, although there are exceptions to that. So with that transplant hospital, they work up the living donor, and really the waiting time for this recipient candidate will be dependent on finding that living donor. And once the living donor is approved, the recipient is approved, they're a match, then a transplant can occur. So the key here is that the waiting time really does not depend on being on a list. It really just depends on whether you have someone to donate to you. And unfortunately, there are not enough living kidney donors. Again, 90,000 patients in the US waiting for a kidney transplant, but in 2023, only about 6,290 transplants were from living donors. And as you can see on the graph at the bottom, there's this basically stagnant rate of living donation in the US over the last decade. It's really the deceased donors that have been increasing. So how can we increase living kidney donation? Now, there's many ways to increase it. I'm going to focus on three things. One is individualizing risk assessment. Second is addressing immunologic incompatibility. And third is removing financial disincentives. So how do we individualize risk assessment? So there is an old paradigm wherein when we had a donor come in and we're trying to evaluate the donor, we had all these criteria, right? Whether it's age, whether it's the amount of protein in the urine, whether it's blood pressure or kidney function or the presence of stones or BMI or A1C, fasting blood glucose. So we looked at all these characteristics in isolation and said, well, if you don't pass all of these or you fail to meet one criteria, you're really not a candidate. So all of these potential donors were assessed really with each clinical characteristic examined in isolation. Now there is a new paradigm to say that it is really more I think reasonable to assess candidates in the context of all the characteristics taken together. So what do I mean by that? We've had a better understanding now of risk thresholds and looking at all these risk factors and what they mean as far as risk. And when we talk about risk post-donation, of course, one of the things we worry about the most is risk for kidney disease post-donation. So when you think about risk, there are donors who have had, their donation attributable risk, which is something we will obviously control as far as advising a donor candidate to proceed or not. But there are also aggregate risk related to health characteristics in the absence of donation, and these demographic related risks in the absence of donation. So these are inherent risks that are already present that we can't really do anything about as far as changing a course, whether a donor donates or not. So the decision to accept or decline a donor candidate is then grounded on the candidate's estimated post-donation lifetime risk. And that takes into account the risk that's already present in the absence of donation. And based on the study that looked at registry data of donors who have proceeded to develop end-stage kidney disease, there are now tools out there, this has been around for a really long time actually, of projecting the incidence of end-stage kidney disease in potential donors. And this calculator that I'm showing you is one that is a pre-donation lifetime risk. So this does not take into account that post-donation risk in the brown graph that I had shown earlier, the brown in the graph. So you can use these demographic and clinical characteristics to estimate that projected long-term risk. And then that can inform the acceptance criteria for kidney donors. So here I just show you two different donors and how this can be very different. So you have somebody who's older, 60 years old versus a 30-year-old, a white donor candidate versus a black donor candidate, and then different GFRs, the younger person having a better GFR, both on blood pressure medicine. BMI of the younger donor is lower at 30, and then there is some albuminuria. And you can see here for the younger donor that pre-donation lifetime risk is 8.4% as opposed to 0.72 for someone who is older. So I think this gives us a better picture than looking at things in isolation where you say, okay, I have this person who's on blood pressure medicine, well, she can't donate, right? Very different for someone who's 60 versus someone who's 30 years old. Here at University of Chicago, it's a place very well known for kidney stone research and clinicians with expertise in kidney stone disease. One of my colleagues, Sam Krishnamurthy, who's a transplant nephrologist, has pioneered a nephrolithiasis protocol for our donor candidates where we individualize the stone risk assessment, whereas before, when somebody, for example, had kidney stone in both a history of 2 kidney stones or a kidney stone in either kidney, that was an automatic exclusion criteria. what we've done is personalizing that risk assessment of why this person has developed a kidney stone. Are these risk factors reversible? And essentially having a flow sheet working with our general nephrologists in figuring out whether a candidate can still proceed to donation. So that's individualizing risk assessment. I move on now to addressing immunologic incompatibility. So I want to just give you a brief sort of overview of what immunologic incompatibility means. So in kidney transplantation, for us to successfully transplant a kidney and an allograft, a kidney into a recipient, this requires both HLA, human leukocyte antigen compatibility, and blood type compatibility. So a recipient should not have antibodies that are preformed so that's to avoid what we call hyperacute or early acute antibody-mediated rejection. So for example, you have a donor here who has, a recipient here who has two potential donors. You know what this patient's antibodies are to HLA. So this recipient has all these antibodies, and you see here donor 1, their HLA type, and donor 2, their his or her HLA type. And you see here that for donor 1, the recipient candidate has antibodies against A2 and B57, which donor 1 has. So this is an incompatible donor, whereas donor 2 does not have HLA that the recipient has antibodies against. So this is a compatible donor. So what if this recipient did not have donor 2 as an option and all you had is donor 1? What are things that you could potentially do? So one thing we could do is kidney pair donation, which I will talk about in the next slide. And another one is desensitization. So kidney pair donation has become very popular over the last decade or so, wherein incompatible pairs can exchange their donors for the recipients. So if donor 1 and recipient 1 are not compatible and donor 2 and recipient 2 are not compatible, well, donor 1 can donate potentially to recipient 2 if they are compatible, and then recipient 2's donor 2, will then donate to the other donor's recipient. So then you get 2 transplants that are both compatible, and you have 2 successful outcomes. And then this also can occur in a chain, which is actually, I think, more common these days, where you have a person who comes forward and says, I want to be a donor. I don't have anyone specifically I want to donate to. We put them in a chain or a registry where we identify a recipient that donor would match with. This is particularly powerful when you have a blood type O donor who comes forward. And that can set off a chain of transplants where recipient 1 gets a kidney, then recipient 1's donor then donates to another person, that person's donor then donates to another person, and so on and so forth. And as you can see here, like I said, over the last decade, that has really, of all the things in living donor that's increased, it is the paired exchanges that have increased. So in 2022, almost a fifth of living donor kidney transplants were performed through donor exchanges, the largest of which is the National Kidney Registry. It's not the only one that's out there, but definitely the one that I think is most robust as far as the number of pairs enrolled. So this National Kidney Registry has facilitated close to 10,000 transplants at this point. All right, and then moving to desensitization. So we're trying to, in desensitization, you're actually trying to do a direct donation between an incompatible pair. And what you're really trying to do is to remove those preformed antibodies in the recipient such that you can have a successful transplant. And the way we do it, I think the classic way to do it is to give intravenous immunoglobulin, plus minus plasma exchange, and also giving rituximab. I'm not going into the details of how that's all carried out. There's many protocols out there, but here I'm showing you multi-center data that shows that for people who have received incompatible transplants, their survival is superior to waiting for a kidney transplant that is compatible or simply waiting and never getting a transplant. What they don't show you here is the results of a compatible transplant, that survival. But again, you're looking at patients here that, are probably very highly sensitized and don't really have that option. So they end up waiting and waiting and waiting and until they get a transplant. And they do worse than those who are actually desensitized. So the new thing in desensitization that's very exciting is this drug called inflamidase, which is an IgG degrading enzyme that comes from Strep pyogenes, which cleaves all four human classes of IgG. And what it can do is it can cleave those anti-HLA antibodies. It can rapidly degrade them. And so those antibodies disappear. You do your transplant, you avoid hyperacute rejection, and then you treat that antibody with other things where be it plasmapheresis or other drugs. And there's a phase 3 trial that just ended. This is actually the results of the phase 2 trial where they show that there is an effective DSA reduction. DSA meaning donor-specific antibodies or those antibodies against HLA. And that at 6 months, there was 89% graft survival and all patients were alive. And a phase 3 trial of this drug just ended. We were very fortunate to have been able to participate. We don't expect to hear about results for another year probably. And if there is benefit, probably this drug won't be in the market for another 2 or 3 years is my guess. So that's one thing. And then exciting things we're doing at University of Chicago is one of my colleagues, Yusuf Kiso, who's also a transplant nephrologist, is doing some novel desensitization regimens. This is in collaboration with one of our basic scientists, Anita Chong, who is very well known for her work on antibodies, and our surgeon, Piotr Witkowski. And they're trying this approach of using carfilzomib, which is a proteasome inhibitor, and belatacept, which is a co-stimulation blocker, and using that without doing any plasmapheresis. So this is just a schematic of the protocol and what they do. And what you see here is that these are levels of those anti-HLA antibodies. Each bar represents an antibody. You see here a patient who has many, many antibodies. So pre-treatment, you see higher titers, and post-treatment, you see lower titers and less of them. And then I think we've done over 10 of these types of desensitization, and all these graphs have been functioning after a year. So we're very proud of this work, and we're still trying to develop this further. All right, and then the last point on how to increase living donation is removing financial disincentives. I think this is an important topic for the public to really know about because there is advocacy that is involved. So, the cost to donor workup and the hospitalization of a donor and the care, that's covered by the insurance of the recipient. But I think it's not very obvious to a lot of people that there are also other financial there are other expenses that are not necessarily related to that, such as lost wages, cost of travel, paying for childcare while you're doing the donation and recovering, out-of-pocket expenses. Donors are exposed to employment insecurity, insurance insecurity, and even physical labor impairment. They can go back to their job, but they can't really lift, their 50-pound, do the 50-pound lifting that they do in their daily job. And this is a study that I show you published in 2023 on the right, that the mean out-of-pocket direct cost per donor is estimated to be about $1,200. And if you really think about indirect costs as well, meaning childcare, travel, things like that, it may come out to as much as $45,000. And ironically, every living donor that we do affords Medicare $33,500 of cost savings per quality adjusted life years. And so I really like this quote from Syed Hussein and Crystal Lentin about living kidney donor transplantation, which saves both lives and money. But strikingly, accrual of these benefits requires risk-taking by the only party who receives no direct benefits, and that's the living donors themselves. So I think that's really food for thought. But what is out there to support our living donors? We actually have federal support for living donors in the form of the National Living Donor Assistance Center, or called NELDAC. It's federally funded. It has a $9 million annual budget, and it aims to reduce financial barriers. So it does provide some support for those who qualify. I think the important piece here, there are key limitations where not everybody qualifies. So you have to be a citizen or a lawful resident. The donor candidate can also only have a maximum 3 donor candidates per recipient. And then there's a reimbursement cap of $6,000. And I think the biggest caveat here is that the qualification is really based on the household income for a recipient. And the recipient has to be below 350,000 of the federal poverty level, or approximately $69,000 for a household of two. So if you have a donor who's struggling, but the recipient makes enough money to not qualify, then that donor cannot get federal support. So there is legislation out there advocating for increasing, the parameters by who would qualify for NELDAC. That's yet to be approved. There are many actually laws that are out there, but I want to highlight the Living Donor Protection Act. So I have the privilege of being a part of the ASN Public Policy and Advocacy Committee, and we've gone to the Hill to advocate for this. This has been going on for over a decade, which is essentially a bipartisan bill that prohibits insurance companies from denying or limiting coverage or raising their premiums, and including a living donation as a serious health condition eligible for FMLA. Now, there's many reasons why this bill has not passed. We were very hopeful it would be passed last year. It didn't happen at the very end, unfortunately. So we're back to reintroducing it again into Congress, into this Congress. And you see here there are other bills out there that ASN in particular, NKF, and many other organizations are advocating for. Now, at the state level, this is also interesting that every state has different types of living donor protection. And this is a map from the Kidney Fund, American Kidney Fund, a group of patients that rate, an organization of patients that rates states by how well they have protection for living donors. So you see here, I came from Tennessee. Tennessee has a grade of F. I moved to Illinois and we have a grade of A. And I just ran into this problem recently because I had a donor who was being denied life insurance or being charged very high premiums. He donated in Illinois. Unfortunately, he moved to Indiana and now lives in Indiana. And so he's having a lot of trouble. The state laws in Indiana are different from Illinois. So they grade states based on these criteria. And you can see here that for the Living Donor Protection Act that we are trying to advocate for in Congress, it will actually give them a grade of C, give every state at least a grade of C. So if I were Tennessee, I would probably benefit from it. Now, I'm sure you're wondering where is Kentucky. So I looked it up the other day, and Kentucky is a C as far as grading. And that's a C because the state has protection from life, disability, or long-term care insurance discrimination and job protected leave from public employers, but none of the others. All right, so the second half of the talk, I'm going to move quickly. We're going to talk about reducing organ discards next. So I showed you earlier how you get to a living donor transplant. Now I'm going to show you how to get to a deceased donor transplant, which is a lot more complicated. So I'm going to take you through this step by step. So you have a candidate who's referred to one of the 251 transplant centers. The transplant center evaluates this candidate and says, okay, you are suitable for kidney transplant. You can get on the list. So they get on a waiting list. And that can be anywhere between 4 to 5 years or even more based on blood type, based on other characteristics. But the median is about 4 to 5 years. All right. And then after that amount of time, there is a deceased donor who then becomes available at a donor hospital. So this is usually not in the same hospital where the recipient is. It's very rare that that happens. And when a deceased donor's family says, I want our loved one to be able to donate, they interact with what we call is an organ procurement organization, and there are 56 of them in the country. So here in Illinois, it's Gift of Hope. In Kentucky, I actually don't know what they're called, but we call them CODA, KYDA. That is how they go by, CODA. So these 56 OPOs then work with the deceased donor family at the donor hospital. They start managing the donor. They take over the care essentially of this deceased donor. And then the OPO, which is short for Organ Procurement Organization, then interacts with the transplant center. So there is a match run that occurs on DonorNet. I will show you that in the next slide, that tells them who are the centers that are being offered this kidney, or which patients are being offered this kidney, I'm sorry, which patients are at the top of the list and where are they. So then they get this list of the patient and what center they're listed at, and the OPO then interacts with the transplant center. Organ allocation occurs, the transplant center accepts, and you have transplant occurring. But while all that is occurring, the kidney somehow needs to get from the donor hospital to the transplant center where the recipient is at, and that kidney is put on ice, and that's what we call cold ischemia time. So actually, before I show you the match run, I want to talk about the just ABCs of deceased donors. There are many things we think about as far as deceased donors, and there's nomenclature associated with it. So one is it brain dead or is it a donation after cardiac death? So brain dead, these are the majority of our deceased donors. They're the ones who die of a stroke. They have a gunshot wound to the head. They have head trauma from a motorcycle accident, and they're declared brain dead, and that that satisfies a definition of death here in the United States. And donation after cardiac death, however, is another increasingly type of deceased donor that we are now being offered. Is these are folks who are not doing well. The family decides we want to withdraw care. We want our loved one to become a deceased donor. And so essentially the donor goes to the operating room, and that's where withdrawal of care occurs. And once that donor is proclaimed dead by their medical team, that is the only time that the donor team comes in. So what happens here is that these donors have what we call warm ischemia time, where the kidney is actually not being perfused, right? Because this donor has gone into asystole, with no blood pressure and has been declared dead by the lack of blood pressure. So, and by the asystole. And so this has some warm ischemia time, and I'll explain why that's relevant later. And then we have this KDPI, or Kidney Donor Profile Index number, where we rate available deceased donor kidneys, or the donors donating these kidneys, from 1 to 100%, 1 being one that we predict will do the best as far as longevity of the graft, and 100% being the worst. And this is a relative scale. And then finally, we have these donors with increased infection risk. There's different criteria as to who satisfies that. There are also donors with hepatitis C that we know of, who have hepatitis B, who have COVID, who have HIV. And these are all potential kidneys from donors that we can transplant. So I'm going to go back to the KDPI. It's a numerical measure that combines 10 donor factors. Actually, now it's 9 donor factors. The race from that equation has been removed. That summarizes into a single number the quality of these deceased donor kidneys relative to other recovered kidneys. So I think I just explained that to you. But to show that the highest KDPI are the ones that have the lowest survival long-term, over 10 years, whereas the lowest KDPIs are the ones that last the longest. So how do we reduce these organ discards? 1, we can improve organ allocation. 2, we can reduce delayed graft function. And 3, we can utilize these higher risk kidneys. So how do we improve organ allocation? Well, one way to do it is to modernize the transplant system. So again, another schematic of how complicated the system is. I was telling you about how a candidate is at a transplant center, an OPO is dealing with a deceased donor. All this is actually overseen by the Organ Procurement and Transplantation Network, which was established in the 1980s by the National Organ Transplant Act. And so it's the OPTN currently contracted to an organization called UNOS, and there's a lot of news about that because UNOS is going away as far as what their current responsibilities are, that oversees this full process. So I was talking earlier about how you find out who among the recipients on the list are offered a kidney and the OPO then figures out which centers they're in, it's through this match run that occurs on a website called DonorNet. All right, so it's literally a list where patients line up, and based on their characteristics, they will get a certain allocation score. It's called a kidney allocation score. A lot of what drives that is how long someone has been on dialysis or how long that person has been on the list. But there are other factors that bring you to the top of the list, whether it's you have a lot of antibodies and you're hard to match and things like that. So it goes through a computer system where we all list our patients, and this is DonorNet. All right, and there's an algorithm of who gets this offered these kidneys based on KDPI. So those who have a lot of antibodies, hard to match, they get priority because if there's a kidney out there that somehow miraculously matches with them, they'll get the offer. And then the sharing of these kidneys also depends on how close you are to the donor. So where is the recipient transplant center relative to the donor hospital? And there is priority given to every transplant patient recipient in a transplant program that's within 250 nautical miles of the donor hospital. So you see here inside circle before the national allocation, so to speak. Now, it used to be that this circle was much smaller and it was divided into what we call donor service areas. That went away. And this broader sharing has really led to this increased complexity of how kidneys get to their recipients. And really what has come out of this is, at least arguably, that the complexity leads to longer cold ischemia times and higher discards. That all this contributes to this discard rate that is now at about 25%. So about 25% of all potential deceased donor kidneys for transplant actually do not get placed. And the number one reason for this is that no recipient was located. And so my colleague, who most of you probably know in the nephrology world, Dr. Michelle Josephson, who's now 2 years past her presidency of the American Society of Nephrology, she, along with the ASN, really moved to focus on advocating for the modernization of our organ procurement transplant network, focusing on improving technology, data transparency, governance, operations, and quality improvement and innovation. And this is by no means just the ASN. It's many, I think, organizations that advocated for this that led to the approval or passage of the Securing the OPTN Act in September 2023. So what's happened basically is that now there will be different contractors that will be taking charge of the different facets of managing our organ transplant system. So what UNOS is doing all on its own over the last few decades is now going away. As far as just UNOS, there will be other entities involved. So I'm not going to go this into detail because I do want to spend a little bit of time on this, which is a new thing called the Increasing Organ Transplant Access Model, which is a Medicare mandatory model that has just been approved and is set to begin in July 1 of 2025. So this model will provide incentives for transplant hospitals to promote the following goals. And you see here, maximizing the use of deceased donor kidneys, identifying more living donors, providing greater access to kidney transplant by addressing social determinants of health and other barriers, improving care coordination, and reducing Medicare expenditure. So Medicare will reward programs that are able to do more transplants, do more living donor transplants. There is a score for all of this. But not all transplant programs are going to be a part of this. It's half of the country, essentially, and they divided it by the donor service area, so the classic regions serviced by these organ procurement organizations. And I'm looking here, Kentucky is not a part of it, and neither is Illinois. But I think this will be interesting. It's really the first time CMS is directly working with the transplant programs themselves to encourage them to do more. All right. Another way to reduce organ discards, and again, by no means are these the only 3 ways to reduce organ discards. These are simply what I was hoping to highlight today. The second one is to reduce delayed graft function. So what is delayed graft function? it's essentially a session of dialysis in the first 7 days after transplants. That's how it's defined. And these days, about a third of deceased donor kidney transplants experience DGF. There are risk factors for this, those that I described earlier, the donation after cardiac death, because of that warm ischemia time, because there's no flow to that kidney, they're prone to ischemia, reperfusion injury, they are prone to delayed graft function. Donors who have recipients who have CKD, donors who have CKD risk factors of acute kidney injury. The organ itself, if they have long cold time, they're in on ice for a prolonged time, the type of preservation that's used. And then for the recipient, of course, some of these other factors that we can't really do much about. And why is this relevant? It's because these risk factors that lead to DGF are also the same risk factors for kidneys that are more likely to be discarded. Whether they're DCD, whether they have high KDPI, whether the donor has a higher creatinine or the donor has hypertension. These are the types of kidneys that are more likely to be discarded. And so reducing delayed graft function potentially can reduce this idea of, well, this is a DGF kidney. This is something I'm scared to use because it might never work. How can we reduce DGF? So I think this is relevant in that, there are tools out there to try to do this. And one way is to do what we call pumping, which is the more formal term is hypothermic machine perfusion. So when you have a donor in a donor hospital, usually the standard is, at least one standard is for that kidney to go in a cooler, right? So we all know about this cooler that has an organ in it filled with ice, and then it gets transported to the transplant center. But another way to do it is to actually put it on a pump. So there is a pump that perfuses cooled perfusate, and then it can travel with this donor kidney, or it can stay on a pump and then go on ice and then get to the transplant center. And why is this important? We are using this more and more these days with the broader sharing that I showed you, where we have longer cold ischemia times, more donors are donation after cardiac death. This is what a pump looks like. And we see here that even from 2009, we have good data to show that there is reduced DGF with machine perfusion as opposed to static cold storage, and importantly, graft survival is also superior. So this is something that I think is increasingly being utilized. But what's out there? I think another potential way to reduce DGF and potentially increase utilization of kidneys is through this normothermic regional perfusion, which is essentially performing ECMO on a deceased donor and rehabilitating that kidney prior to transporting to a transplant center. So this is now increasingly being used in thoracic organs and even in livers. For kidneys, we're usually, we see this when a kidney comes with a liver or kidneys, the donor's heart and liver were also procured, and the kidney comes along with it. And so there are very early reports that there's a significant reduction in DGF. Although with these small studies, no difference in short-term patient and graft survival. So this is, I think, something that's going to be discussed in the future, whether it's cost effective. There are also some ethical concerns as to whether or not, this is really violating some of the things as far as the definition of brain death, especially when it's regarding thoracic organs where they're ligating the vessels going to the brain. Whether or not, there is actually reperfusion to the brain happening. So you're going to hear more about this, but wanted to highlight something that's, I think, for the future. Okay, and then utilizing higher risk kidneys. What are these higher risk kidneys? Again, these are the kidneys that may be prone to delayed graft function, the donation after cardiac death, donor with acute kidney injury. These can be kidneys that come from donors with comorbidities, and in that manner, because of that, their KDPI then is pretty high. So the high KDPI kidneys, and then these kidneys that have Hep C, Hep B, COVID, and HIV. So I think one of the things we struggle with a lot as a transplant program is we have a lot of these kidneys. These kidneys are available, the high KDPI kidneys in particular. And how do we put that kidney into the right recipient? So not everybody is going to do well with a high KDPI kidney. And these are some of the questions we ask ourselves. What is the candidate's anticipated waiting time? Is this somebody who's about to get an offer for a kidney that of their choice, or is it someone who's going to wait for another 5 years and they're at this point 75 years old? What is the kidney's life expectancy? So similar to that. And then what are their comorbidities? So for those who are older, greater than 65 years old, for the most part, we do encourage acceptance of a high KDPI kidneys because we do know that this is beneficial. And this is a nice study that I think illustrates this very well. So titer refers to the time that you have equivalent risk of dying or getting a transplant. So for patients who are 65 and above and list for high KTPI kidney, so they list for all the kidney 0 to 100, these patients have a longer time um, until they achieve that probability of dying or removal from the wait list is greater than being transplanted. Whereas those who opt to not list for the high KDPI kidneys, and I'm sorry I didn't mention this, but for you to list for high KDPI kidneys, you actually have to provide your consent. So if a person does not list for this greater than 65 years old, you see that by 11 months as opposed to 25 months, their probability of death or being removed from the waiting list exceeds transplant. So I think the message here is that for older patients, if you're not listing for these higher KDPI kidneys, you're less likely to get transplanted. So a lot of these patients, although they're waiting for a better kidney, they end up not getting to a transplant. They end up either dying or being removed. And then midodrine is a big one. For the nephrologists, some centers you might hear say, okay, they're on midodrine, we can't accept them. And this really stems from a study that showed that those on midodrine have higher risk of delayed graft function and graft loss at 1 year. So here you see graft survival for patients, especially with DCD kidneys and these high KDPI kidneys. ECD is sort of the older equivalent of that, shows that much less kind of inferior graft survivals. And so I think this really scares a lot of programs as to whether to proceed when someone is on midodrine. They generally don't do well with certain types of kidneys. And I think my argument would be here, if you're on midodrine, you really need a living donor kidney or a kidney that probably works right away. And then we use, hepatitis C kidneys now pretty routinely. This just started as a practice in 2017 when we had this pilot study that showed that 10 patients received kidneys from hepatitis C infected donors, and they all did well. They were all cured with direct-acting antiviral therapy. And this practice is now, again, common and outcomes are the same. And you see here, this is encouraging. Discards for HCV kidneys in orange has now approached what we do for non-HCV infected. And you see here, it's about 25%, unfortunately. Hepatitis B is a new thing here at UofC. One of my colleagues, Yvonne Alcasis, is working on getting a program for us started. Not going to talk much about that, but now looking at hepatitis B infected donors. Okay, and then the last 5 minutes, I'm going to talk about xenotransplantation because I think this is really exciting for our field. It's been in the news. So again, 90,000 patients in the US waiting for kidney transplant. Can we transplant all of them? Maybe supplement the 26,000 we have as far as donor kidneys with big kidneys. And it's been in the news about how a first living patient received a big kidney transplant. This is from UAB. A xenotransplant is defined as transplanting an animal organ or product into a human to cure disease. Utilizing genetically modified big kidneys could provide an increased supply for those needing a kidney transplant. So how does this occur? And it's really CRISPR technology that has allowed us to do this. So the gene editing has allowed our scientists to remove antigens in the pig that humans recognize, and then inserting human genes into this pig gene, and then transferring that into porcine fibroblasts, and that fibroblast, that embryo is then implanted into a surrogate gilt. And from that surrogate, you have offsprings that now have kidneys that's been genetically modified. And so these kidneys now have none of these pig antigens that we humans would recognize, and then are more like humans. And so these are the pig kidneys that are being transplanted into humans. The milestones are that we started with transplanting these gene edited pigs into deceased human beings. So those who've already been proclaimed dead, the family agreed that they would, have their loved one become a what we call decedent model. So surgeons transplanted these pig kidneys into a deceased person. They observed how the kidneys did, and we learned a lot from that. And in the news last year was the first pig kidney transplant at Mass Gen and another one done at NYU. Unfortunately, both of these patients did not have a good outcome. The first patient, Richard Sleeman, passed away from, I think, cardiovascular complications. Is not clear to me, but nothing related to the transplant. The transplant was working at the time of his death. And then the second patient at NYU had an LVAD, I believe. The kidney really never worked. Sounded like the blood pressure was low and they couldn't really sustain good flow or good pressure to the kidney. Again, not very clear to me what those details are, but the kidney had to be removed. Now, there is a third human being who's received a kidney a transplant from a pig, who is alive and doing well. And this transplant was performed December 17. This was at NYU. And just 2 days ago, there's news that the FDA has now approved pig organ transplant trials for patients with kidney failure. So the first trials, I think, are about to start. Very few numbers, I think 6 patients per trial. So this is, I think, exciting and breaking news that we're going to be watching very closely. There are issues to consider for these next steps and the unknowns. So what are the optimal gene edits for these pigs? Is it the 10 gene edits that's been used, or some have done more gene edits? What are the constraints of cloning or breeding these pigs? It's still unclear what the optimal immunosuppression is. Of course, there's always a concern for pig-derived infections, the risks of longer-term acute rejection, some physiologic considerations. For example, can these pig kidneys produce enough EPO, for example, to prevent anemia? How long can these grafts survive? Is it 3 years? Is it 5 years? Is it 3 months, 6 months? We don't really know. And then as far as clinical trials, who should be eligible? And then once this is approved, who should be eligible for real-world xenotransplantation? How will the availability of these xenotransplants impact organ allocation? Will it be cost-effective? And I think, what are the satisfactory outcomes? Is it, if, you get them off dialysis 1 year, is that good enough? Is it 3 years? Is it 5 years? It's really hard right now to say what the answers are. And I think still things that we're trying to figure out. All right. So, and that leads me to summarize what I talked to you about this morning, which is, although kidney transplantation is the best option for patients deemed suitable to receive a kidney transplant, there are not enough kidneys to provide this life-saving therapy. Living kidney donation is the best type of kidney transplantation, but can be, and we can increase this by individualizing the risk assessment of donor candidates, utilizing paired exchange, and this desensitization for donors who are incompatible with their recipients, and removing financial disincentives for kidney donors. And then finally, the incredibly high rate of organ discards should be addressed with more efficient organ allocation and transplanting higher risk kidneys into appropriate recipients. And sorry, there's one more. Xenotransplantation is an exciting prospect for patients and a potential solution to the organ shortage. However, barriers remain and much is still unknown. And with that, I want to thank you for your attention today. I want to thank my transplant nephrology colleagues, our entire U Chicago kidney transplant team. I always tell them that teamwork makes the dream work. The rest of the section of nephrology, and my husband and my 2 kids who have been supportive throughout my career. Thank you very much.
Thank you so much, Dr. Concepcion. We have just a couple of minutes for questions. I see one question in the chat that we'll go ahead and get started with, and then we'll have others chime in if they'd like. So Dr. Emmons asked, can you comment on the current status of the use of hematopoietic stem cells to induce tolerance for renal transplant, originally done in Boston and now at larger programs like UCLA? Is this still a niche technology varying from center to center?
Yes, there are definitely centers who are very interested in this, and a lot of the tolerance studies the tolerance is still and for the most part under clinical studies. So there are some trials of tolerance that are going on, and there's people who are interested. We are enrolled, we are a center for one of these, but nothing that I think is mainstream at this point. So I think if somebody is interested in a tolerance study, enrolling in that would be great. And again, as you mentioned, there are centers like UCLA, Northwestern here in Chicago has a lot of interest in that.
Thank you. Dr. Usef, did you have any questions?
Yeah, that was an awesome talk. Thank you so much for giving it. I have one of my interests is more like a safety net kidney. So if someone agrees to take this high KDPI kidney and it's really not working, struggling at a year, if they have to go back on the list, my want would be that they would get their time back. Is there any move for that?
That's such a great question, and that's a question I've asked, whether that's a policy that we would want to look at. There's no move to do that at this point. So what happens is if a kidney does not quote unquote work well, and the GFR of a recipient remains less than 20 mLs per minute in the first 90 days, the center can declare that as what we call a primary non-function, and those patients are the ones that can get their time back. I think the most unfortunate outcome is somebody who actually has a kidney that kind of works. So maybe their GFR is 23, 24, and it's been a year. They're off dialysis, but they're really advanced CKD, right? And so they're still exposed to all the issues with CKD, whether it's volume overload or all the other issues with that, and they can't really get their time back. So what is the criteria for a safety net right now? It's not really safety net, it's simply primary non-function. And I think that whether we should expand that, I agree. I think that might entice more people to actually accept these high KDPI kidneys when they're hesitant, because it might not last very long. But as far as I'm aware, there's no policy move to go that route at this point.
Thank you.
Yeah, that's too bad. Is there another question in the chat?
No, we don't have any more
Okay.
questions right now.
Can I ask another question then?
Course.
Do you do APOL1 testing for your living donors?
Yes. So there's two things to this. We are part of the Apollo study, which is looking at which has actually already ended as far as enrollment, but we were part of that as far as testing donors for APOL1 and looking at their outcomes. But as our standard of care, yes, if someone identifies as African American, we offer APOL1 testing. We don't require it. And so it's really up to the donor as far as whether or not they want to proceed with that testing. And I think the more controversial part is what to do with that, right? So if you have
Yeah.
high risk alleles, in somebody who has who wants to donate, as a group, what's your sense of that donation attributable risk in someone with two high risk alleles? We don't really know. But I do think that our program has decided that for younger African American donors who have two high risk alleles, we counsel them not to proceed. And I think every center probably does it a little differently.
Well, thank you. We're in the last minute of our time here. And first of all, just want to say thank you so much. This was a really incredible update. Very informative. And I think, Jason, are you there to
Oh, yes.
present our token of appreciation?
Oh, yes. So Dr. Concepcion, is a tradition here with the UofL Department of Medicine and our grand rounds, especially for our guest speakers. We have a little gift for you that's synonymous with Louisville. So you will be getting your very own personalized Louisville Slugger bat.
Wow. Thank you.
Yeah. So,
That's amazing.
yeah. So I'll get some information from you, and we'll get this together and get it shipped to you. And we really appreciate you talking to us today. It was
Thank you so much. It's my
outstanding.
pleasure. Thank you for the invitation. This was great.
Thanks.